Hello everyone. In today's class we are going to study about secondary syphilis, its clinical features, the great variations in its presentation, its diagnosis and treatment. We'll try to cover latent syphilis as well in this class. The pathogenesis of secondary syphilis has already been covered in the first part of syphilis. Just a quick revision. Secondary syphilis presents round about 2 to 12 weeks after the chancre. At the time of presentation by a patient of secondary syphilis, you might see concomitant chancre in about 10 to 40% of patients. There is a term known as syphilis D-emboli. Here what happens? There is no primary chancre in the course of the disease. The patient directly presents in the secondary syphilis stage. This happens especially when there is infection of Treponema pallidum via the blood transfusion route. We should remember the secondary syphilis is a systemic disease. Unlike the primary chancre where the treponemes are localized and presents as an ulcer, here the treponemes has already disseminated into the body via the circulation, gets seeded at various parts of the body and then gives the clinical presentation. So the patient might have constitutional symptoms like fever, headache, malaise, weight loss, sore throat and muscle pain. So a patient of secondary syphilis will present with mucocutaneous symptoms and might even have systemic complaints. In mucocutaneous complaints, it can be either mucosal or cutaneous, and a special condition known as Lewis maligna, which is very important to know for a student. In mucosal lesions, there are mainly two types of lesions, the mucus patches and the condyloma lata. Now we see a case report which shows the classical mucus patch which was positive for treponemes. It was treated with penicillin and it healed very nicely. Now we'll see a picture of the tongue. These are well defined plaques with loss of the papilla of tongue that has become smooth. These are very classical of secondary syphilis. This picture is from the CDC Image Health Library. The next is very specific for syphilis. It is condyloma lata. These are flat topped verrucous papules seen over the mucosa and the cutaneous part as well from at the mucocutaneous junction. So we can see them over the groins, over the vulva and over the perianal region. They are often confused with the viral warts. And it is a very often asked question how to differentiate between condyloma lata and the condyloma acuminate. The condyloma lata are flat topped and they are moist and they are teeming with treponemes when seen in dark field. While in condyloma acuminata they are dry, they have acuminate endings and they are negative for treponemes. Now moving to the cutaneous syphilid. Cutaneous syphilid has a very varied presentation. It can mimic anything and everything. It can be either macular, papillary or pustular. Macular syphilid is also called roseolar syphilid. Basically, it is an exanthematous erythema associated with generalized lymphadenopathy. It is the earliest eruption of all. It comes as discrete, round, rose pink or coppery, non-confluent, non-scaly eruption which might be pruritic sometimes. Starts on the trunk, especially around the navel, shoulder and flexors of upper limb, and it rapidly generalizes. Palms and soles and face are spared, but it might be involved later. It is often overlooked because it is very transient and evanescent. Usually doesn't leave any mark, but may have PIH sometimes. The color is due to the engorgement of blood vessels without the cellular infiltrate. It is associated with generalized shorty lymphadenopathy. Now moving on to the papular cutaneous syphilid. It is the most common and most characteristic rash of secondary syphilis. It is represented by discrete, round, dull red or coppery papules and very often scaly and indurated. It has a polymorphous presentation, but very characteristic is the collarette of scales that overhangs the border of the papules and plaques. Clinically, it can present like any disease, but these are the most common types of presentations of papular cutaneous syphilid. One of the most common presentation is the papulosquamous type. It has adherent scales over the papules and plaques, and it presents like a psoriasiform eruption. Next clinical variant is the lichenoid syphilid. Here we can see how it resembles the lichen planus. Sometimes it is also called follicular syphilid when it is concentrated over the follicular ostia, and it might be associated with quite a bit of itch. Next variant is the annular syphilid. Here the papules are arranged as ring and there is a central clearing. It is especially seen on face and at angle of mouths, as we can see in this picture. Historically, it was also referred as nickels and dimes. A very interesting variant is the Corymbos syphilid. Here there is a large central papule with small satellite papules around it. Next variant is the nodular syphilid. As we can see in this picture, there are multiple nodules. It is also known as tumorous syphilid. It might be painful and tender, and it resembles erythema nodosum. This is a case report. We can also see the spirochete marked with black arrow in the lower part of the picture. It is a case report published in QJM, an international journal for medicine. Next lesion is very characteristic for secondary syphilis. These are split papules. These are hypertrophic, fissured papules at oral commissure and sometimes at the creases of ala nasal. Let me just zoom in to show you the clinical picture of the split papules. The next two types, I couldn't collect a clinical picture, but I'll try to explain it to you with a diagram. The corona veneris. Papules arranged linearly along the forehead hairline. This is the corona veneris. And next is leucoderma coli. It is also known as collar of Venus. These present as depigmented macules or papules along the neck. Most of the images are from the CDC Public Image Health Library. One is case report and one is from DermNet, which has already been watermarked. We have done with macular syphilid and the papular syphilid. Last variant is the pustular syphilid. These are papules with central necrosis due to end arthritis obliterans that leads to crusted papules and ulceration. There are four variants. Miliary pustular syphilid, which are small acuminate lesions. Acneiform or varioliform, which are large acuminate lesions. Echthymatous or impetiginous, which are shallow ulcers, while rhupoid, which are deep ulcers. Now moving on to some specialized regions of the body where secondary syphilis can present. And palms and soles, if any lesion is present on them, asymptomatic. On a background of proper history, it is always good to rule out secondary syphilis because these are very characteristic sites. They have hyperpigmented hyperkeratotic plaques, and especially if these plaques have collarette of scales around them. There are some special terms given like Klaus syphilix, which means diffuse hyperkeratosis on the palms and soles. Syphilis corni, where there is cone-like eruptions on palms and soles. Biath's collarette, that means scaling around the papules of and plaques of palms and soles. The moth-eaten alopecia, which is a patchy, non-scarring hair loss, is seen in syphilis. Here in the picture we can see the moth-eaten alopecia over the scalp. We can also see alopecia of the eyebrows in the lower picture. Now coming to the nails. Nails are lusterless, brittle, may have pitting, even onycholysis and paronychia. As already said and explained, syphilis is a systemic disease from the outset. It can present with constitutional signs and symptoms like fever, myalgia, etc. Generalized lymphadenopathy, where the lymph nodes of most of the regions might get enlarged and they might be shorty or rubbery in consistency. The GIT might get affected, presenting as gastritis or ulcers. There can be hepatitis leading to jaundice and deranged LFTs. There can be acute membranous glomerulonephritis or nephritic syndrome in the kidneys, conduction defects in the heart. The CNS can be affected, leading to asymptomatic CSF abnormalities, increased intracranial pressure, meningitis, cranial nerve palsies, or even transverse myelitis. There can be cerebral artery thrombosis. Next, coming to the eyes, there can be uveitis, iridocyclitis, chorioretinitis, and even blindness in some cases. Moving on to the musculoskeletal system, there can be arthritis, osteitis, periostitis, bursitis, and myopathy. The blood picture might show anemia, increased ESR, and leukocytosis. To understand why these many symptoms present in secondary syphilis, you should know the pathogenesis of secondary syphilis, which I have explained in details in the first part of the syphilis lectures. Now moving on to the diagnosis of secondary syphilis. The dark field microscopy very easily detects the treponemes in the wet lesions of mucosa, especially the condyloma lata, which are teeming with bacilli, and the lymph node aspirate. The VDRL and RPR and the TPHA both are always positive in secondary syphilis. The primary syphilis, the secondary syphilis, and the early latent syphilis all have the same dose of treatment, benzathine penicillin 2.5 million units, a single dose IM. We should know something about latent syphilis. Latent syphilis is a condition where there is no clinical signs and symptoms, but the serology of syphilis turns out to be positive. It is seen in 60 to 70% of untreated patients that they remain latently asymptomatic for the whole life. To label a case as latent, complete workup is essential, including the specific serological tests, chest X-ray, X-rays of the bone, the CSF examination, and even fundoscopy of the eyes. Now, if a patient presents with no cutaneous signs and symptoms, but the serology we see is positive, we should check other systems of the body to tag that patient as latent syphilis under ideal conditions. Latent syphilis is divided into early latent and late latent, and it is according to the duration from the time of infection. If it is less than 1 year, according to CDC, it is early latent. More than 1 year is late latent. But if we see the WHO classification, the cutoff time is 2 years. If the duration is less than 2 years from the time of infection, it is early latent syphilis, while if it is more than 2 years, it is late latent syphilis. Early latent syphilis is infectious and the treponema pallidum divides more rapidly. It needs a shorter therapy, that is just a single dose of benzathine penicillin 2.4 million units IM. While late latent syphilis is non-infectious, the treponema divides less rapidly and they need longer therapy, at least 3 doses of benzathine penicillin weekly. There is a term known as relapse in syphilis. It is seen in 25% of untreated syphilitics. 75% relapses within the first 6 months of the infection, while 90% relapses within the first year. There is seen that there is no relapse after 5 years of infection. Relapses can be either clinical relapse that resembles secondary syphilis but is less extensive, and it predominates mainly in the oral and the anogenital region. There is also something known as serological relapse. Here, once the patient has turned serologically negative, again turns positive. This is due to raise in antibody titers, which had fallen with treatment, or maybe due to the passing time from the time of infection. Now, with this, we have come to the end of today's class on secondary syphilis. Thank you for watching. If this has helped you to clear the concepts, do like and subscribe. There are many other videos in the channel. You may go through them. We will meet in the next class of tertiary syphilis. For now, bye.